Good morning, everyone. Lauren, I'll just move to Portuguese just a little bit.
Sure.
Bom dia a todos. Estamos ao vivo em mais uma reunião geral pelo Departamento de Psiquiatria da Faculdade de Medicina da Universidade de São Paulo. Hoje é um dia muito especial, que temos aqui uma convidada internacional falando sobre um tema que talvez seja pouco discutido, ou quase nunca discutido nas nossas rodas de conversa, mas que é muito importante. Além disso, a gente tem aqui uma das nossas maiores especialistas brasileiras também no assunto, a professora Vera, que vai nos ajudar com certeza. Para começar, eu queria apresentar a professora Lauren Osborne, que ela é diretora do Centro de Reprodução de Mulheres e Saúde Mental, professora associada de Psiquiatria e Ciências do Comportamento e de Ginecologia e Obstetrícia da Escola de Medicina da Johns Hopkins University, onde ela também dirige uma bolsa de pós-doutorado em reprodução e psiquiatria. Ela vai falar sobre depressão pós-parto, Postpartum Depression, etiologia, curso clínico e tratamento. Etiology, clinical course and treatment. Com foco na Rexanalone, que é uma medicação nova e que acredito que todos nós vamos precisar saber aí minimamente para os próximos anos. E para comentar, como eu disse, a honra de ter a professora Vera Tess. Ela é médica assistente do IPQ e coordenadora do ambulatório de gestantes do serviço de interconsulta e é mestre em psiquiatria pela FMUSP. E é claro, a presença do nosso chefe do departamento, o professor Orestes, que também vai fazer os comentários no final. So, Lauren, it's a great pleasure to have you here. I'm sure our residents and our professionals from our hospital, we are the largest hospital in whole Latin America. So our department is the greatest psychiatry department in Latin America. So it's a great pleasure to have you here talking to us, and I'm sure it will be very, very, very helpful to our residents in their formation. So you have 1 hour of your presentation. Please go ahead.
Okay, wonderful. Thank you so much. It is a real pleasure to be here. I'll just get my slides going. Okay. All right, is everybody able to see that?
Yes.
Okay, so I'm going to get going. It's a real pleasure to be here, and thank you so much for the invitation. I always love meeting people and seeing how psychiatry is done in other places, and I'm always happy to talk about my favorite topic, women's mental health. I don't have any financial conflicts of interest. I do have some funding that I'll acknowledge at the end. So what are we going to try to do here today? We're going to try to understand the 3 main mood syndromes of the postpartum and what distinguishes postpartum depression from these other mood syndromes and also from postpartum obsessive compulsive disorder, which is an important thing to know about. We're going to talk a little bit about standard treatments for psychiatric disorders during the postpartum, including lactation, but that'll be relatively brief because then I'm going to try to spend the bulk of the second part of the presentation on the science behind the use of neuroactive steroid modulators, i.e. Rexanalone, in postpartum depression. So why do we have to care about this topic? And I don't know what the statistics look like in Brazil, but here in the United States, we have a shocking U.S. maternal mortality rate that is very high and rising. As you can see, we're way, way above many other developed countries, and it's only getting worse. And we have a particular problem with mortality rate for people who are non-white, and especially Black women, non-Hispanic Black women, have 3 times the mortality rate of white women in this country. And it's shocking and it's devastating. And of course, a lot of that mortality rate has to do with mental health disorders that are not recognized and not treated the way they need to be in the peripartum period. So that's kind of the statistics behind what drives the work that we do. I'm going to talk a little bit, I'm going to start out by talking about a case because I think it's always helpful to think about how a patient would present with these conditions. And then I'll weave discussion of that case through what we do. So we're talking about Mary Jones. She's 34 and she's 3 weeks postpartum with her first child. She's referred to the psychiatrist by her obstetrician after 2 weeks of difficulty sleeping, worries about her health and her baby's health, poor appetite and concentration. She's feeling shame over difficulty breastfeeding. She's got nausea. Her stomach is in knots. And her partner is reporting that she's standing by the window for long periods, not sure what's going on with that. There's been a medical workup that's benign. So what are we talking about here in the postpartum? I think it's really important to remember that the postpartum is both psychosocially and biologically a time of severe vulnerability for severe mental illness for women. I think this graph kind of says it all. After the first child, there's this huge spike in what we're seeing here is rates of first-time psychiatric admission in the first 30 days postpartum. And you see with the first child, this enormous spike. What that represents is that women having their first child in those first 30 days postpartum have 23 times the likelihood of being hospitalized inpatient for a psychiatric emergency as they do at any other time in their lives. Unfortunately, with subsequent children, that goes down. And as I said, there are both biological and psychosocial reasons for that. So when we see a woman who presents with some kind of mood symptoms in the postpartum, as this case Mary that I mentioned to you, there are basically 4 things that we need to really think about. The baby blues, which is not a psychiatric disorder, postpartum depression, postpartum psychosis, and postpartum obsessive compulsive disorder. So what's the baby blues? It's something that happens to almost all women. Onset is about 1 to 10 days postpartum, usually earlier. It generally lasts for 2 or 3 days, and by definition, it must last less than 2 weeks. And it's a syndrome of mood lability. There can be tearfulness, irritability, crying for no reason, sometimes laughing for no reason. And it occurs in about 80% of women. So it's not a psychiatric illness. It's not related to prior history, and it's likely related to the abrupt hormonal shifts that occur at parturition. During pregnancy, estrogen and progesterone go up exponentially, about 100-fold for estrogen. And then we go over a cliff in the 24 hours after childbirth, and those hormones drop down. And this mood lability syndrome of the baby blues is likely related to that shift, and it's completely normal and healthy. Most women will go through it. The keys to diagnosis are what's the severity of symptoms and what's the time course. So the question is, we think about that case, Mary. Do her symptoms fit in with this syndrome? And the answer is no, right? And the reason it's no is that she's presenting with 3 weeks postpartum and reporting over 2 weeks of symptoms. So the time course doesn't fit. And she's also, sounds like she's got some pretty severe symptoms. She's feeling shame over her difficulty breastfeeding. She's standing by the window for long periods for unknown times. She's feeling like she's not a fit mother. So baby blues doesn't fit the syndrome that we presented with that case. What about postpartum depression? What's that? Well, there's a lot of controversy actually over how you define postpartum depression. If you look at the DSM diagnosis, it's now coded as with peripartum onset, which means onset during pregnancy or within the first 4 weeks postpartum. And it's true that many women present that way. Many women present with antenatal depression, and some women present in the postpartum. Some women have depression that crosses both time periods. But biologically, those are probably 2 different things, right? There's a different biological state going on during pregnancy than during the postpartum. So I actually don't like that DSM definition because it elides those 2 things. And clinically, many people use the word postpartum depression to refer to anybody in that first year postpartum who's depressed. But that also doesn't make a lot of biological sense because the biological shifts that have to do with changes in hormones in the immune system happen closer to pregnancy. So scientifically, I like to think of postpartum depression as a depression that arises in those first 4 to 6 weeks postpartum. And then women who become depressed later in that postpartum year, it probably has more to do with psychosocial aspects, or biologically, perhaps with weaning. But however we define it, it occurs in about 15 to 20% of women. It differs by population. And there are known risk factors: your prior psychiatric history, a family or personal history of previous postpartum depression, and then the same risk factors that are risk factors for many types of psychiatric illness: poor social support, single moms, low socioeconomic status, stress, marital discord. The way you distinguish it from those baby blues is the time course, right? It's an episode of depression, so it has to last at least 2 weeks. The severity of symptoms: anybody who's presenting with suicidality or other severe symptoms can't possibly be the baby blues. Even if she's presenting with less than 2 weeks of symptoms, it's going to be a depression that just hasn't met that time course yet. And the degree of functional impairment. Are these women able to go about their day, do what they need to do, or are they having significant impairment in their functioning? And what's their psychiatric history? If there's somebody with a prior history of depression, then chances are it's depression, right? So does this definition fit the symptoms of that patient I presented? Yes, it could. But from everything that's been presented so far, this is a plausible diagnosis. But what about the other mood syndrome that occurs in the postpartum psychosis? It's actually kind of a poorly named syndrome. It's an affective syndrome, even though it has the word psychosis in it. Of course, there are psychotic symptoms, but there have to be mood symptoms also. And this is a very rare syndrome, only 0.1% of the population. So we've gone from 76% baby blues, 15 to 20% postpartum depression, and now 0.1% for postpartum psychosis. And it's characterized by a confusion and disorganization. It looks like a delirium. There's that waxing and waning of consciousness. Women often have decreased need for sleep, increased activity and energy. So those mood symptoms that accompany this syndrome are most often mania, but can be mixed symptoms or can be depression as well. There will be psychotic symptoms, especially delusions about the baby or fears of harm coming to the baby. And there's a very high risk of suicide and infanticide in this syndrome. And that makes it a psychiatric emergency, right? Anybody you see with this syndrome needs to be hospitalized. And it's in the United States, at least, I'm not sure how it is in Brazil. In the United States, when we hospitalize a postpartum woman, she is separated from her baby. So a lot of physicians are reluctant to do that. But in the case of postpartum psychosis, it's really necessary. So the question is, does this fit Mary's symptoms? Well, it's not clear, right? We definitely saw some mood symptoms, but we also had that hint of something odd going on. She's standing by the window, staring out for long periods of time. Are there psychotic symptoms that we haven't asked her about? Could be. Is there suicidality? Could be. We don't know yet. So it's possible that this syndrome could fit Mary's symptoms, but we need to ask more questions of her and especially of her partner to try to understand more of what's going on. And then the other thing that I like people to think about as a differential in the postpartum is postpartum obsessive compulsive disorder. It's not a mood syndrome, but it's actually extremely common in the postpartum, and it's something that you will never uncover if you don't ask the right questions. So postpartum OCD typically presents with intrusive thoughts and images, often those concerning infant harm. And we're not really sure what the prevalence is. Early studies showed a prevalence of somewhere from 3 to 9%, with OCD in the general population being about 2%. But there was just a paper that came out a couple of months ago that found a prevalence of up to 17%. So we think the prevalence is much higher than we tend to think it is because we're not asking the right questions. So women who have onset of OCD in pregnancy, it's often associated with contamination obsessions and cleaning and washing obsessions. Whereas women who have onset in the postpartum, it's usually intrusive thoughts of infant harm, and the compulsions will be avoidance and checking. So a good example would be, I'm afraid I'm going to throw my baby out the window. And you might avoid that by steering clear of windows entirely. Or I'm afraid I'm going to harm my baby somehow when I change the diaper. Therefore, you say my partner's going to change all the diapers. So content can often be violent, sexual, or religious in nature. And overt compulsions are less common than covert behaviors or mental compulsions. I'm afraid my baby has a dread disease. I'm going to spend all night Googling to try to find out what this disease is. I'm going to take my baby to a lot of doctors. But the clear distinction between postpartum psychosis and postpartum OCD is that in OCD, these thoughts are ego dystonic with preserved insight. So in other words, they're horrifying to the woman. She's never going to act on them. They're unbidden thoughts that just pop into her mind, and she recognizes them as not realistic, but they're there anyway. Whereas in postpartum psychosis, they're delusions, they're fixed false beliefs that the woman may believe in. So could this fit Mary's symptoms? Well, it could, right? We haven't asked the right questions to know. We've seen some mood symptoms, but we also have this odd behavior of standing by the window. Is she having some kind of intrusive thoughts that have to do with the window? We don't know if we don't ask, and women will never reveal these thoughts if you don't specifically ask because they're ashamed, and they don't understand that it isn't associated with an increased risk of harm. And here's a really good way of distinguishing between those two syndromes, OCD and postpartum psychosis, thinking about what are obsessions and what are delusions. The other thing to point out is that there's a really high prevalence of obsessions in postpartum depression, so a high comorbidity. So many women with postpartum depression will also have obsessions. There's actually been some data that show that 100% of women in the postpartum will have intrusive thoughts of harm coming to their child. So maybe not them causing the harm, but harm coming to their child. For most women, these are fleeting. And about 50% of women will have intrusive thoughts of themselves harming their child. Again, for most women, these are fleeting and not impairing. But for a subset, they become impairing and they affect functioning. So why do we have to distinguish among all these syndromes? Why don't we just say she's ill in the postpartum? Doesn't matter what we call it. Well, the reality is that treatment differs. If you have baby blues, you don't want to treat it. It's not a psychiatric syndrome. It doesn't need to be treated. It resolves on its own within 2 weeks. For postpartum depression, we treat it as a major depressive episode. For postpartum OCD, we treat with antidepressants, but we need higher doses of SSRIs in the OCD than we do in postpartum depression. And also cognitive behavioral therapy is gold standard treatment for postpartum OCD with exposure and ritual prevention. For postpartum psychosis, lithium is the gold standard treatment, maybe with antipsychotics and benzodiazepines for symptomatic relief, but lithium is, some studies have shown 98% of women with postpartum psychosis will respond to lithium. The data for the neuroactive steroid modulators, i.e. Rexanalone, at this point is specific to postpartum depression. So we don't know whether it would work in postpartum psychosis or postpartum OCD. And so at the moment, it's restricted to women with postpartum depression. So let's go back to our case, Mary, for a second. The symptoms that I outlined at the beginning, as I said, could be compatible with all the syndromes except the blues. So the doctor asks some more questions, and on asking those questions, she reveals some more history and some more current symptoms. She tells about a history of anxiety that she had in high school and one prior episode of depression. She took 15 Benadryl at that time, that's diphenhydramine, to escape. Says it wasn't a suicide attempt, she just wanted to get away. She didn't have treatment for that episode, but it did resolve eventually. This difficulty she's having sleeping is not because she has excess energy and a decreased need for sleep, but rather ruminations and worry. She does not report any intrusive thoughts or bizarre beliefs. She's convinced that she's a terrible mother, and her baby would be better off without her. And she's never tried any psychiatric medications. So now that we have this other information, it becomes clear that this is postpartum depression, right? She's got no intrusive thoughts, so it can't be OCD. She doesn't have any bizarre beliefs. She doesn't have that excess energy that's common in postpartum psychosis. This is a true case of postpartum depression. And she's made it easy on us by having no prior medication trials, so the world is open to us in terms of how we treat her. So a couple of words about why to treat postpartum psychiatric illness. A lot of people have a belief that that we shouldn't bother to treat it because it only affects the mother and not the child, and because anything we do while a mother is breastfeeding might be harmful to the baby. So why don't we just let the woman, deal with it instead of treating? But the reality is that postpartum psychiatric illness actually has devastating effects on women, children, and families. So women with postpartum depression have poorer bonding with their baby. It leads to family discord and a whole host of poor child development outcomes, including effects on IQ, language development, behavioral and conduct problems, and psychiatric illness in the child. And we know that those effects exist even if you separate out the effect of women who are depressed in pregnancy or the genetic component. So that those are effects exclusive to that situation of postpartum depression. So that's bad for the baby. It's also very bad for the woman, right? Suicide and infanticide I mentioned in postpartum psychosis, but they're also a possibility in postpartum depression. And in fact, suicide is a leading cause of maternal death in the first year postpartum, accounting for up to 20% of all deaths. And that suicide risk increases about 70-fold in the first year postpartum over other times in a woman's life. Some countries track suicide as a pregnancy-related death. I don't know if you do that in Brazil. I hope you do. We don't here in States. So we can't track exactly where it fits in terms of other pregnancy-related deaths like eclampsia, hemorrhage, other obstetric problems. But some countries do track it that way. And in the countries that do, it's often the leading cause of death in the first year postpartum. So let's talk about a general approach to treating. I'm not going to go into detail about all the medications that we can use. That could be the subject of a whole other hour presentation. But I'll just talk a little bit about a general approach. And the first thing to know is that all psychiatric medications do enter the breast milk, but that doesn't mean you shouldn't use them because most of them are compatible with breastfeeding. At least the American Academy of Pediatrics has set a threshold of 10%. 10% meaning if less than 10% of the maternal dose gets into the breast milk, for the most part, they think that medication would be compatible with breastfeeding. And all of the SSRIs, and with one exception, and most other antidepressants and most psychiatric drugs are under that 10% threshold. In the US, we have a high proportion of women who at least initiate breastfeeding. So about 90% of women at least initiate giving some breast milk to their children. There's not a great rate of sustaining breastfeeding, but at least 90% of women try, and that means that there's at least some period where this is going to be a concern. So when you're choosing a medication in the postpartum, the most important things to think about are the history of prior medication use, right? If there's a medication she's used before that works for her, then you want to use that unless it's something contraindicated, and there's almost nothing that is contraindicated. I have a lot of people who say, well, she responded before to citalopram, but I know that sertraline passes into the breast milk in a lower amount than citalopram, so shouldn't I switch her to sertraline? The answer is no, because we know she has a history of responding to citalopram, and that's going to be what works for her. We don't know if sertraline will work for her. We also have to think about the age and health of the baby, right? A baby who's premature, whose liver is not yet mature, who can't metabolize medications, that baby's more likely to have adverse effects to ingesting breast milk with medication, whereas an older, more mature baby is less likely. It's also important to remember that if a woman was treated during pregnancy, there's no logic to changing treatment for lactation. She's going to get less of that medication into the breast milk than across the placenta. So this is just a general approach to think about how we do this and to emphasize that it is really important to treat and that most of the medications that we use are safe. For antidepressants, they are all compatible with breastfeeding. And so really you should never hesitate to treat postpartum depression. So let's talk a little bit about the newest treatment, Rexanalone, and there are some other neuroactive steroid modulators being studied. Let's talk about the science behind it, why it makes sense as a treatment for postpartum depression, and then a little bit about how it works and what the data show. So first of all, we have to take a step back and say, well, what are neuroactive steroids? Rexanalone is a synthetic version of a neuroactive steroid. And the term neuroactive steroids refers to all of these molecules that are descended from cholesterol that have effects in the brain. Most of them are made in the brain, but they can also be made elsewhere and then cross into the brain. Oh, sorry. Went too fast. For our purposes, when we're talking about illness in pregnancy and postpartum, it's the molecules that are descended from progesterone that are particularly important. And the one that we are particularly concerned with is Allopregnant. It's an allosteric modulator of the GABA-A receptor. And you can see here from this picture that the GABA-A receptor has a bunch of different subunits, and the conformation of those subunits actually changes drastically across pregnancy and postpartum. So that's something to just keep that thought in mind. We're going to talk a little bit more about the receptor later. But you can see that this is the receptor to which benzodiazepines bind, but in a different site than where the neurosteroids bind. So it's an allosteric modulator. It doesn't bind at the same site as benzos, nor does it bond at the same site as GABA, but it has the effect of having the same actions on the brain as GABA. So GABA is the major inhibitory neurotransmitter, right? It has a calming effect on the brain, and that's what neurosteroids do as well. And I think the easiest way to think about it, or understand how this system works in the body, and now I'm just talking about in, endogenous, not giving Rexanalone, but how does this work naturally in the body? Well, let's say you experience a stressful event. When you experience that stressful event, the body's reaction is actually to decrease, GABAergic function. So you decrease GABA, that makes anxiety go up, and that tells the body to compensatory action of increasing levels of neuroactive steroids, which will have the same effect as the missing GABA. When you do that, then the GABAergic function improves and your anxiety goes down. So that's the way it works in a normal, healthy person, right? But we know that people who have chronic mental illness actually have lower levels of those inhibitory neuroactive steroids. So that feedback loop can't happen the way it's supposed to because their levels are low. And we also know that SSRI antidepressants will reverse that. So people with mood disorders have low levels of allopregnanolone and other neuroactive steroids. You take an SSRI, and one of the actions of the SSRI is to improve those levels, thereby improving that natural feedback loop. But the pattern, that's true for people with chronic mental disorders like major depressive disorder. The pattern is actually very different in some reproductive psychiatric disorders, for example, premenstrual dysphoric disorder. What I'm showing here is allopregnanolone levels in people with PMDD. And what we see in the top is irritability score for a woman with PMDD across this cycle. You can see that her symptoms come on in the luteal phase and then plummet down as soon as she hits the next, sorry, that keeps doing that, hits the next cycle. And you can see in the bottom half of the slide what happens with her allopregnanolone levels, which lag a little bit behind that, but she actually has major symptoms in the period when the allopregnanolone is declining. And also has symptoms as the allopregnanolone is rising. So we think that there's a U-shaped or reverse U-shaped curve here, where what women are responding to is possibly the steepness of the rise or the steepness of the decline or that fluctuation. So a different pattern than we see in major depressive disorder. So what's it like in pregnancy? Is it like major depressive disorder or is it more like PMDD? Well, there are all sorts of neuroactive steroids that can change during pregnancy. I'm not going to go through the details of this slide at all, but it's just another way of showing how many of them are descended from progesterone. Here's allopregnanolone, but there are all of these other molecules. Everything in yellow on this slide is an inhibitory neuroactive steroid. So we've done a lot of research on allopregnanolone, but there are also all of these other compounds, and they're all working together. The ones in blue are actually excitatory, so they would have the opposite effect. Allopregnanolone, though, is the one that has had the most research, and it's the one that serves as the basis for Rexanalone. So we're going to focus in on allopregnanolone and what we know about it in pregnancy and postpartum, and why we were able to, well, not we, I didn't do it, why people were able to develop the Rexanalone drug. So allopregnanolone, as I mentioned, has this effect of being calming on the brain. It also has a lot of other actions on the brain. It improves myelination, it regulates the HPA axis, and it regulates inflammation. And I personally think that that's a really important function, that crosstalk between neurosteroids and the immune system. But again, I could give you a whole other lecture on that. We're not going to get into that too much today. In normal pregnancy, what happens to allopregnanolone? Well, as progesterone rises, so does allopregnanolone, to the point where levels are 7 to 9 times higher by the end of pregnancy. But it drops before delivery. So a few weeks before delivery, the ratio of allopregnanolone to its immediate precursor in that metabolic path from progesterone, that's what we're showing here in this graph, it drops a few weeks before delivery. And there's also a difference in the expression of the GABA-A receptor subunits and in their binding capacity, and those change across pregnancy, and they have to do with these fluctuating levels of allo. Everything's returning to normal by about 6 weeks postpartum, but there's definitely this huge increase and then a drop toward the end of pregnancy. There's a lot of data on allopregnanolone levels in pregnancy and postpartum, but it's conflicting data. Some of these papers showed that low allopregnanolone in pregnancy was associated with concurrent symptoms of depression. Some of them showed that low allopregnanolone was not associated with concurrent depression. Some of them showed in the postpartum that high allopregnanolone was associated with postpartum depression. And a few studies have looked more longitudinally to see over time, is it associated with perinatal depression, but they often don't make that distinction between pregnancy and postpartum. So conflicting data definitely showing that there's some kind of relationship, but we're not entirely sure what it is at this point. This is the most recent study that was done, and it examined multiple neuroactive steroids, not just Allopregnant, across pregnancy and the postpartum, and had great strengths of being a longitudinal measure and having these multiple different neuroactive steroids. But it used a group of people who were just at risk rather than people who necessarily had postpartum or antenatal depression. And it looked at mean levels rather than changes across time. So we still don't quite have the answers we need. We also think that there's a genetic contribution. What this is showing is a study of AKR, which is the enzyme that controls that metabolism of progesterone down to allopregnant. And there's some evidence that polymorphisms in the gene that controls that enzyme may be related to reduced levels of allopregnant and to depressive symptoms. We also think that the receptors are key. So I mentioned before that the receptor conformation changes across pregnancy. And what we know is that allopregnant is an allosteric modulator of that GABA-A receptor. Its immediate precursor, and remember I said that ratio changes across pregnancy, its immediate precursor actually inhibits GABA-A, so it has the opposite effect. And there are also some isomers of allopregnant that will also have the opposite effect. So what that means is that it's really crucial where allo gets in the metabolism and what the conformation of subunits is. There's been some animal data that showed that if you knock out the GABA-A receptor, you're going to have increased mood and anxiety-like behaviors postpartum, but not at other times. So that indicates that the receptor is behaving differently in the postpartum period than it does at times where a woman is not postpartum. Well, in this case, where a mouse is not postpartum. My own group has some data showing that allopregnant levels early in pregnancy will predict the development of postpartum depression. So in this study, we found that each additional nanogram per milliliter of allo that a woman had in the second trimester reduced her odds of developing postpartum depression by about 63%. Now, obviously, that's not a direct effect, right? Second trimester is a long way away from the postpartum. So there's definitely links in the chain that we haven't figured out yet. Maybe it's receptors, maybe it's that connection with inflammation, but definitely there's definitely some role. And so all of this research plus, 20 years of basic science research before it has what has led to the idea of using allopregnant as a drug for postpartum depression. We also, this is just an example of how they alter that GABA-A subunit composition. So you can see that over the course of pregnancy, in a normal healthy pregnancy, the delta subunit increases and the gamma-2 subunit decreases, and those have effects on tonic and phasic action of the GABA-A receptor, whereas in a woman who's having anxiety or depressive symptoms in pregnancy, that doesn't happen the way it's supposed to. And the result is that in the postpartum, we don't have enough of that delta subunit, which helps to buffer the calm. So all of that information about how neuroactive steroids works and the 20 years of animal work on the relationship between allopregnant and mood disorders generally and peripartum mood disorders specifically was what went into the idea to develop this as a drug for postpartum depression. And when it was approved in the United States, which was about 2 years ago, it was a very exciting moment for those of us who work in women's mental health, because of two reasons. First of all, politically, there has never in the United States been a drug approved for postpartum depression before. There are drugs that we use, absolutely, but there's never been one with an indication for postpartum depression. So we felt like it was a big achievement for the recognition that women's mental health, and especially perinatal mental health, is something important that we need to consider and that we need to consider separately from mental health at other times. So mental health symptoms that arise at these times of reproductive transition may be distinct, may be biologically distinct from mental health symptoms at other times and may need different kinds of treatment. So that was one exciting reason for this approval. The other exciting reason was the mechanism, right? We do not have a lot of psychiatric drugs with new mechanisms being developed. At least in the US, the pharmaceutical companies aren't crazy about developing new psychiatric drugs because there's not enough money in psychiatry. So it's been a long time since we had very many drugs with new mechanisms. We've had a few others, right? Ketamine came along a few years ago. but there aren't that many. So it was a new mechanism, and it was a mechanism that made so much scientific sense with all of those years of research backing it up. So those were the positives. The negatives, as you can see, and this is a headline from the New York Times right after it was approved. The negatives are, and the other positive is that it works very quickly. The response is within 48 hours. The negatives are that it's extremely expensive and it requires a hospital stay. So let's look at a little bit of these data and try to tease out how this drug works, whether it works, why it works, and what are the pros and cons of using it. So this is how it works. I've explained before that Allopregnant is an allosteric modulator of the GABA-A receptor, and Rexanalone is just a proprietary IV formulation of Allopregnant. So it does exactly the same thing. It's this positive allosteric modulator of the GABA-A receptor. And you can see here just a picture of the receptor, where GABA attaches and where the neuroactive steroids attach. The PAM is the term that they're using for that here. So the therapeutic rationale is what I explained to you in all of those other slides, that we know that GABAergic hypofunction has been associated with postpartum depression, and that it ought to work by increasing GABAergic function. And the amount of Rexanalone that's given returns the woman to a third trimester level of Allopregnant. So remember, we went off that cliff in 24 hours postpartum. Levels don't completely return to normal until about 6 weeks postpartum, but drop largely in those first 24 hours after that modest decline toward the end of pregnancy. And so when you give Rexanalone, you put a woman back into her third trimester state. How does it work? Well, you have to admit a woman to the hospital for 3 days. I love the fact that it says here screening period days -3 to -1, as if it would take you only 3 days to screen the woman and get her in the hospital. Ideally, that's how it works. I can tell you that it takes us a lot longer here to do it, primarily because of bed status. We're administering Rexanalone here at Hopkins on an inpatient psychiatry unit. Most places that are doing it on obstetrics or on medicine, partly because of the bed status and partly because of the needs for monitoring, which I'll explain to you. So it was approved by the FDA, but there was concern over sedation, and the FDA approved it with a requirement that pulse oximeter be monitored for the entire length of the infusion. So a woman has to have a continuous pulse ox monitor, and somebody has to be able to respond to that. In most hospitals in the US, that means putting a woman on obstetrics or on medicine, where we have telemetry, where a woman can be just hooked up to a monitor all the time, and there's a central nurses station where that can be monitored remotely, even if there's nobody at the bedside. Here, we're doing it on psychiatry, where we don't have that technology in the psychiatry units, and we looked into installing it, but the building that the psychiatry units are in is so old that they can't install the technology there. So our solution has been to have a one-to-one staff with this woman all the time. So she has just a standard pulse ox with a digital readout, and she always has a staff member with her to monitor that pulse ox. So that makes it a very intensive hospitalization and an inexpensive hospitalization. So the first 12 hours, there's a dose titration as the woman ramps up to the full dose. Then for 36 hours, she maintains that full dose infusion, and then there's a 12-hour ramp down, and then a period of post-infusion. Some places you'll stay in the hospital for 4 days to get to that post-infusion. We've been doing it in 3 days. We admit patients always early on a Monday morning, and then we have them out by Wednesday night. So let's look at the data. We said that there were political reasons and mechanistic reasons to be excited for this drug, but there were also some downsides. So is it something we should be getting excited about? How well does it work? Well, the first study that was done was an open label study. And I remember when this study was being done, it was incredibly dramatic because these patients who all had a prior history, there were 3 patients with a prior history of postpartum depression. And they were also taking psychiatric medications, but those medications had not changed for a while. And they came in severely depressed. They had a mean Hamilton score of 26.5 on entry. And as you can see from this graph, they also had high scores on a number of other depression scales, including the Edinburgh Postnatal Depression Scale. They were also anxious. They had high scores on the PHQ-9. And you can see that they had an immediate and drastic response. So they went from a Hamilton score of 26.5 to an average score of 4.8 just in the first 12 hours. And they maintained that through the infusion. So these were very exciting data, and certainly seem worthwhile pursuing it further and deciding, what is the next step? So the next step was a placebo-controlled phase 2 trial. It was a masked study, so neither the patients nor the treaters knew who was getting the drug and who was getting the placebo. And as you can see in this study, there was also a dramatic response. So we had Hamilton scores going again from a high of 28-ish down to about 8 within those first 12 hours of the infusion. You can also see that there's a placebo response, but it's not nearly as dramatic as the response of the drug. And they did 2 different randomized placebo-controlled trials in the next phase. So this was very encouraging. It was done of 1 dose, and it was only with women with severe postpartum depression. And that 1 dose was a high dose of 90 micrograms per kilogram. The next set of studies were placebo-controlled phase 3 trials where they tried out 2 different doses of Rexanalone. And they included women with both moderate and severe postpartum depression. So you didn't have to have a Hamilton of 26, you could have a Hamilton somewhat lower than that, I think down to about 17 for the admission to this study. And you can see here, again, dramatic response in the first 12 hours, but much stronger placebo response than we showed in the first study, and a differential response of the 2 different doses of Rexanalone, with the lower dose actually having a better response than the higher dose. And we can see here that they actually followed this, they then followed this out to 30 days. And by 30 days, at least in this first study, the response crossed over with the placebo response. So the immediate difference was dramatic, but then by the time you got out to 30 days, there didn't seem to be a big difference from placebo. So then they put this all together into an integrated analysis. So took the data from all of these different trials that they did, put it together. And when they combined everything this way, you can see that there's still a pretty big separation between placebo and Rexanalone after those first few hours of the infusion. In this case, there was still a separation at 30 days. The Rexanalone patients were doing better at 30 days than the placebo patients, but it's not as nearly as big as that reduction that we had in the beginning. So what this says to those of us working in the field is a couple of different things. There does seem to be a dramatic and quick acting effect of this drug, and that's worth a lot. When women are postpartum, I mentioned before that there are issues with bonding, issues with family discord if women are depressed in the postpartum. And if you treat them in a standard way with an antidepressant, that could take 6 to 8 weeks to kick in once you're at a therapeutic dose. And sometimes it takes a while to get up to a therapeutic dose. So the advantage of using this treatment is that there's a response within 12 hours and certainly within the 3 days that she's in the hospital. And that means a woman could return to her baby after 3 days with a dramatic improvement that she might achieve on an SSRI only after 6 or 8 weeks of treatment. So that's encouraging, and that's a reason to be excited about this drug. The other thing to think about, though, is why are we having that substantial placebo effect, right? All psychiatric drugs have a placebo effect. You can't find one that doesn't, so it isn't surprising that there's a placebo effect. But there are a couple of things that I think are worth looking into for why there's such a strong placebo effect. How are we treating these women with Rexanalone? Well, we're bringing them into the hospital. We're separating them from their babies, which is not ideal in terms of bonding. But it has an effect that, at least in the United States, is crucial. No matter how many gains women make in the workplace here, women are still largely in charge at home. And women with new babies tend to be the primary caretakers, and often partners are not that not that involved in the childcare, particularly if a woman is nursing, there's a tendency for women to say, well, I should be the one to get up at night because I'm nursing. And so there's a huge sleep deprivation that's going on, and also a huge change in their relationship status. So when you bring a mother into the hospital and leave the baby at home, that has two effects. It gives a woman 3 days to sleep, and you're giving her a sedating drug, so you're letting her sleep for 3 days. And it also means somebody else at home has to step up and learn to take care of the baby in those 3 days. And is it possible that there are lasting changes that come about as a result of that? And so the woman gets better with her 3 days of sleep and rest. She goes home, and there's a difference in how she and her partner are working with the care of the child, and that's what helps to sustain her gains. That's all speculation. We don't have any data on that at all, but it's something to think about and to consider, that how much of this response may be due to the drug and how much of it may be due to the fact that she's hospitalized, resting separate from her baby. What are the adverse effects? So I mentioned before that when the FDA approved it, they were concerned about the sedating effect of the study. And you can see from these data that sedation is the most common. One of the most common side effects. Headache is actually a little more common, but all of the patients were sedated to some degree. Interestingly, there was a higher proportion of people in these data showing sedation on the lower dose than on the higher dose, but there were also some people with placebo showing sedation. A little bit of nausea or infusion site pain, but headache and sedation are the big ones. In the patients that we've treated here at Johns Hopkins, there's been a little bit of sedation, a few headaches, but nothing substantial. And we think the main reason for that monitoring concern is that there was a patient in the early trials who was mistakenly given, I think, a double dose, and that patient was extremely sedated and lost consciousness, and so that caused the FDA to be concerned about, could that happen? I suspect that as we get more data from these patients being treated in the hospital, and we look at the monitoring over time, and we realize that there really aren't substantial adverse effects, I suspect that may eventually go away, and they may take away that requirement for the continuous pulse ox monitoring. That would open up a whole new avenue of treatment, because if we didn't have that requirement, we wouldn't have to put the woman in the hospital, right? We could do this in an infusion center the way we're doing ketamine, where somebody comes in, has the infusion, and then leaves, perhaps an intermittent infusion. Maybe it's infused for 6 hours, 3 days in a row or something like that. So we're not there yet, but I suspect that we may get there. I just want to talk a little bit also about other compounds that are related to this that are not on the market yet, but coming up, and that may change the way we think about treatment with Rexanalone. So the most important one to talk about is Sage 217, which is also known as Zuranolone. So this is an oral compound, and the drug company Sage tested it for both postpartum depression and major depressive disorder. And it took a long time to get to this oral compound, because it's very tricky to make an orally bioavailable drug from Allopregnant. So it took much longer than making that IV drug. They finally were able to do it. They decided to test it in both major depressive disorder and postpartum depression. And it did not meet its primary endpoint in phase 3 trials for major depressive disorder, but it did for postpartum depression. So again, that's encouraging evidence that these kinds of mental health symptoms that arise at times of reproductive transition may be biologically distinct and different from symptoms that arise at other times. An interesting point, I was at a conference yesterday, and somebody presented data showing the huge role of anger and irritability in postpartum depression, and saying, we really need to think of this as symptomatically different as well as biologically different. So for postpartum depression, though, Sage 217 did meet its primary endpoint. The reduction isn't as dramatic as it is with Rexanalone, but it's a reduction of, I think, almost 18 points on the Hamilton versus 14 for the placebo at day 15. And this is a 2-week treatment. You take the drug for 2 weeks, but the difference remains significant after a month. And the advantage of this drug, obviously, is that you wouldn't have to come into the hospital. And it is still a shorter time to treatment than an SSRI. It starts to work fairly quickly. You only take the drug for 2 weeks. You don't have to wait that 68 weeks ramping up to the therapeutic effect. So this is a promising treatment that's not yet on the market, but has been submitted to the FDA for approval. There's also a drug called Gonaxalone, which is another allosteric modulator of the GABA-A receptor. So it's not Allopregnant, but it's related to that. And this has gone through phase 2 studies here in the US. It's also an infusion, IV infusion, but it's only a 6-hour IV infusion, which you then follow by a daily oral pill. So a much more manageable regimen than what we have with Rexanalone. And it did show a significant reduction in Hamilton after the 6 hours and after 24 hours, but that reduction was not sustained out to 28 days. So there's only been an open label for, there's also been an open label for just the oral that has promising data, but these results haven't been published, and it's not clear what's going on with this drug or why we haven't heard more about it. This is just from that, I should have put this before the previous slide, for zuranolone, stage 217 versus placebo in postpartum depression. So I mentioned that the reduction was not as significant as it was with Rexanalone, and there wasn't as much difference from placebo, but you can see that at the primary endpoint, there is a significant difference, and that's sustained out to 45 days. So again, showing that there's promise for this drug for the future. So let's wrap up and conclude, and then I hope we have time for lots of conversation about this. The main points that I was hoping to convey to you today are that postpartum mood syndromes are very common, with postpartum depression up to 15 to 20% of women in the general population, with much higher rates in certain populations, particularly low social support and people with marital stress or discord. But they're very treatable. So we have SSRIs that do work well in this population. They take some time to work, but they do work well. We know that all of the standard treatments for depression are compatible with pregnancy and lactation, so we shouldn't hesitate to treat. And we know that suicide is a leading cause of postpartum death, and that deteriorate, the baby's health will deteriorate. They are a dyad, and so it doesn't make sense in this time to think about whether you treat the mother versus what you're doing for the baby. You're doing things for the two of them together. And we know that a healthy mother is going to be better for a baby than a non-healthy mother. Certainly a mother who's alive is better than a mother who has committed suicide. So there's no question that it's important to treat these and to not be afraid of treating in this time. We also have substantial evidence for the role of neuroactive steroid dysregulation in the pathophysiology. There are tons of other things that are being explored for the pathophysiology. I'm a personal champion of immune dysregulation, and I do a lot of work in that area. But one of those pathways seems to be through neuroactive steroid dysregulation, and that formed the scientific basis for the development of Rexanalone. It certainly seems that these are promising avenues for treatment. They make scientific sense, and the data show that there's a strong and rapid antidepressant response of these drugs. But there's also a very strong placebo response and some negatives, like it's an expensive IV infusion that requires hospitalization. So it's early days yet. We don't yet know how this oral drug will work out there in the real world. It hasn't been approved by the FDA yet. So there's time to learn a lot more about it, but promising and exciting to have a new possibility of treatment for these moms. I just want to finish by acknowledging my funding for the research that I do, and acknowledging all of the amazing colleagues and staff who help me with what I do here at Johns Hopkins. This is a picture of our group in a brief moment last summer post-COVID, when we decided we could all get together in person. I'm going to stop there. I'll end my slideshow and look forward to whatever conversation we can have.
Thank you so much, Lauren. It was a great pleasure to listen to. Professor Vera, please, you can give your comments. We'll be very glad to hear. Your audio is muted. Just click on the microphone. Activate your mic.
That's it. First of all, thank you very much. Nice to meet you. Thank you very much for your marvelous speech. Actually, you say everything about the subject. The first thing I'd like to say is, I think the highest, the most important therapeutic instrument is it's what we're doing now, is to talk about it and to give information. It's an area very new in psychiatry, the perinatal period. Historically, we always take care more after the birth, the postpartum period, and the pregnancy, mainly because of our lack of information and fear. We are talking about fear before your lecture start, and I think here in Brazil it's almost the same as you are talking about. I think, unfortunately, the whole world in that same situation. This perinatal health, mental disease is extremely prevalent here in Brazil. We have a very nice epidemiological study from Rio de Janeiro, which shows more than 26% of PPD, and talk about the general population. But definitely, when we are talking about more vulnerable communities, this number explodes. And as we are a poor country, and definitely with the pandemic shows, unfortunately, and we can see now day-to-day work in the hospital, how the pandemic interfered and was cruel to this population. Anyhow. So one thing we still really have is the majority of the psychiatrists, the medical in general, because here in Brazil, there is the obstetricians and the medical, family medicals, who are the one who take care of the pregnant. And the majority of the doctors and the psychiatry also are very afraid of, and they just don't work with. They send to somebody, but the big problem is we don't have somebody to send to. So these women stay without treatment. So we have this perverse who is that the doctor are very afraid of because of lack of information, and the pregnant and postpartum women are also and still very ashamed of feeling bad in this period of life, that there is a huge social pressure that should be the most important and sublime and marvelous period. Mainly when you were wanted to be pregnant. In this situation, it's almost understandable for the patient and for their family. Their family also. So I thought, this is the huge challenge of us to trainee, to talk to the doctors, to explain to the doctors, to give information that the most important thing is to treat these women. As you said, one thing, I've been working with this population for almost 15 years. After I get pregnant, I was very strong, and it's really marvelous to work with this population. But two aspects really touch me. One is, you just said, it's incredible how a pregnant and after a mother psychological bad will suffering can have a devastated impact in the family. It's something that when you work with this population, you can see in front of you, and it's very anguish because you see the whole family, mainly the children, start to discompensate, and I can see that. My goodness, you are seeing a lot of probably young adults and adults with mental disease in 10, 15 weeks. So to prevent mental disease, I think the focus should be the pregnant woman. Take care of the pregnant after postpartum. And when you say, it's very nice that you talk about the placebo and the Rexanalone drugs that say, look, your supposition, I really agree that something is connect to that, because when you take these women and take care of them, they go to the hospital, everybody's looking to her, listening to her, treating to her, the family and the environment is going to take care of all the stuff that she should be the one who take care. Our reality here, it's completely that the women, the role of the woman is still taking care of everything in the house and the children. And when you talk about the vulnerable, the poor people with no many condition, this is very cruel because she needs to do everything: the house, the little children, the food, and this. I think the worst thing in having a baby is the sleep deprivation. How would say deprivation?
Mm-hmm. Yeah, deprivation. Yeah.
And sleep deprivation.
That's completely crazy. I think everybody. So how you can function properly? Don't sleep. Need to do everything. So one thing that we in our clinic, the goal of our clinic is to treat the patients, of course, from the whole obstetric unit, and to teach the residents. First of all, to not be afraid. Mm-hmm. First of all, that they need to treat, they need to see. And I say pregnancy is not a disease, but it is a very special moment. It's a huge moment in your body and your mind. So the pregnant need to be listened to, need to be treated more especially, and you need to educate the family and the around. So inside of the work we do in our 1 hour medical, because it's a clinical consultation. You don't have huge. It's the doctor with the patient. So inside of that, what you do is, of course, try to do a good diagnosis and to plan a treatment. But inside this treatment, the psychoeducation for the patient and for the family and around, it's crucial to bring people out and to say she needs help. After the birth, she will need a lot of help. If you talk about the cultural, the history of the humanity, the period that whole communities, the only role of the woman should be breastfeeding, sleep, and eat. And nowadays you need to do everything plus that. Yeah. So it's, I think the big challenge is to help the people, the professional, the health system, the health profession, to understand that, and to allow the woman to say, look, it's very common. It's not that you are not able, you're not a good person, you're not a good mother, you're not a fail. You need help. And as you said, the treatment, the second thing that really taught me work with that, it's the response marvelous. When you see them and when you plan a good treatment, a real treatment. It's incredible how you can see the so severe case, and they became well. They can have their birth, to take care of the baby afterwards, and to feel and at level these psychological things that I think the doctor who is responsible for them should be the one to be responsible for, to talk about, to give all this information, and plus the medication. One thing may be different, that in a poor country, we need to think, and it's incredible, but the majority here, even the pediatric don't think, is that for many women, for many children, for many newborn, the only food he's going to have to have condition to have is the breastfeed. It's not a question. The breastfeed is fantastic for all the reasons we know, but the point is, if you say to them that they can, that's the injury, so that they can breastfeed because of the medication, or if we put them in this situation, either you or your baby, either you treat you or we are going to put them in a situation that there is no money to buy a good milk. Good milk here is very expensive. The government, the state doesn't give them. There is no this political, unfortunately. So we have this. We need to treat the mother. There is no healthy baby without a healthy mother, as you said, definitely. And the mother needs to be well, and this baby needs to have the best food feed. So here we have this many times, and even when we talk about lithium and lactation, sometimes it's a very difficult medication for lactation, but sometimes it's either this baby is going to have the mother's milk with lithium, and you're going to take care of both, or she's going to give cow milk with water. It's a disaster. So that's I'm very happy to have, and I hope these medications. When I read 1 year ago about this drug, I say, look, and when Rodolfo said we are talking about this drug, I said, that's not our reality. It's very far away because it's very complex, very expensive. But now you say, I hope in a short time we manage to have better drugs. We have very good drugs that really helps, but as you said, takes too long. Exactly. In a very sensible period. We don't have months to be better. Now there's all can distract, give up a lot of problems for the family. But I hope that these drugs come to the health public, to the public can be possible. And that's it. Thank you very much.
Great. I'm going to put into the chat for everybody. We have a curriculum that we designed for psychiatry residents to learn about reproductive psychiatry, and it's not just at Johns Hopkins. It's a bunch of people across the country who did it, and it's mostly things that you can download, like PDFs you could download and use to teach in a classroom, but people could also do it online, and it's free and available for everybody. So I'm gonna let me just put it into the website, into the chat.
Great. I will share with everyone. Great. Thank you so much. Professor Orestes, please.
Yes, sure. Well, Lauren, thank you so much for this wonderful presentation. It's really amazing. This is a very sensitive and interesting topic. I can tell you something like 25 or 30 years ago, we got a visit from Professor Kumar from UK here.
Oh, wow.
He spent a week with us, very wonderful week, learning a lot from him. And I was very much interested in this whole matter. As a matter of fact, I went to another field, so my patients don't get pregnant. I treat elderly women, and
there you go.
so I'm not in contact so much with this, but it's really, really fascinating to see these developments. So thank you very much for bringing that to us. And you will certainly be invited for another educational session here at our department. Well, I have two objective questions and two more exploratory questions, if you may. First of all, what are the severe and serious adverse events that you can expect from this drug? And if it's advisable to start some SSRI after the infusion, looking at long time effectiveness. So if you could please address this too.
Yeah, absolutely. So fortunately, there don't seem to be really severe adverse effects. The biggest ones are headache and sedation. When we do it on our inpatient units, we have the nurses have to complete a scale, like a consciousness level scale every couple of hours to make sure that somebody isn't slipping into unconsciousness. So far, they've been fairly alert all the way through. Our nurses first thought, when we described the drug to them, they imagined the patients just sort of lying there in bed the whole time, but they've been ambulating, they've been, pretty alert. And there haven't been any other serious adverse effects identified. We don't know about long-term adverse effects because nobody has studied that at this point, and we don't really have much data on breastfeeding safety. We don't know. So most women getting the drug are pumping their milk and dumping it out for the period of the infusion and about a week afterward. So we don't know about that. And then, is it advisable to start an SSRI? Well, interestingly, many of the women who come in, at least here, have already been on an SSRI and they hadn't responded. And they have to have been stable on a dose for 2 weeks. We don't want them having recently increased a dose and then getting the drug, because then you sort of are not sure what's helping. So many of them come in already on an SSRI, they stay on it, they remain on it afterward. If I got somebody who was not on a medication and they came in, had Rexanalone, we don't have data to show that this is necessary, but I personally would start an SSRI because we don't know how long this effect is sustained, right? There's now data that some effect is sustained out to 30 days, but it's a smaller effect. And so I want to try to capitalize on what we have. So I would certainly start an SSRI. It may be that when the oral compound is approved, if it is, that instead of starting the SSRI, maybe you start that, you give them Zuranolone. Another thing that people have been concerned about, and we don't really have data on at this point, is that, well, if it acts on the GABA-A receptor, isn't that where benzos and alcohol act? Is it going to be a substance for which we have to worry about addiction? And a lot of people will argue that it's not, because it attaches to a different site of the GABA-A receptor, and we don't see the same level of tolerance developing to these drugs as we do to benzos and alcohol. But the reality is we don't really know, right? And so the answer is, well, we're giving it in a 3-day infusion and then they go home and they have no access to it, so it doesn't matter. But if there's an oral drug being approved, we don't really know what that's going to show. And so that I'm curious to see how that goes.
Well, that was supposed to be my next question. So what about using other GABA-A modulating drugs? I think that might be something related to pathophysiology. Perhaps Rexanalone is, in a way, rescuing some abnormality in these neuroactive steroids in these women. So maybe you are correcting some imbalance and things like that. And
yeah, I think to some extent that's true, right? It's not just a GABA-A modulator. It's a specific GABA-A modulator that they had in their bodies until very recently, right? So that may be a difference, yeah.
And I also wonder if there are any other indications for
use?
Mechanism of action, such as PTSD or other acute and stressing situations.
Yeah, I'm really curious to see that. Right now, it's only approved for postpartum depression because that's all that's been studied. My guess is we will find other uses. And one of the things that we're doing by using it here at Johns Hopkins is we're trying to gather data on the patients we admit to see if we have some indication that that's useful for other things. I'm admitting a patient next week, actually, who has severe postpartum depression and also has PTSD from a relatively recent trauma. I have no idea if this is going to help the PTSD symptoms. I think it's going to help her depression, but I'm really curious to see. What I have noticed is that we've had some patients admitted who have a severe older trauma history, like they had early life trauma, and they have mental health sequelae of that early life trauma, and then they also have a superimposed postpartum depression. Those patients don't seem to respond very well to this drug. They just don't get better enough. And I think that's because their postpartum depression may not be that pure biological postpartum depression, but rather it's just a complication of their chronic illness.
Such as complex PTSD?
Exactly.
Yeah.
But I just think we don't know enough yet. You know, one of the things that one of my colleagues suggested was we have the medical insurance situation in the United States is ridiculous and complicated. And I mentioned before that there's some insurances that we don't take so that the people can't be hospitalized if they have that health insurance. But there are also rich people who come to be hospitalized here, and they don't care if we take their insurance because they're just going to pay. Well, if a rich person who didn't have postpartum depression, let's say had treatment refractory depression or something else, came in and wanted this drug, could they pay and get the drug? Maybe, and then we would have some data of does it help people in other situations? But I don't know how we're going to get that data otherwise, right? And there aren't that many of those patients. So I think we have to, my colleague's feeling was that it was going to help for a lot of other things. But we have the data from the oral compound that showed that it works in postpartum depression, but not so well in plain old major depression. So I don't know.
Excellent. Well, thank you very much.
Absolutely.
Rodolfo, are there any questions from the audience?
Yes, I have a question from me, and then I'll give an audience question. But my question is regarding ketamine use for this population. Are there some studies? Because ketamine, it's really less expensive than Rexanalone.
Yeah, and it's less expensive, and it's not, you don't have to go in the hospital, and you can just go to an infusion center and get it done. And interestingly, there have not been a lot of studies in postpartum depression. And so I think we should do those studies, right? Because you're absolutely right. It's less expensive and it's less of a burden, wouldn't require separation from the family. But there just isn't a lot of data at this point.
Great. Well, I have a question for audience here. Then by Silly Isler. Considering the mechanism of action, it would work for 50% of depression who have already initiated during pregnancy.
So would it work for women who become depressed during pregnancy?
Yes.
Yeah.
Great. Another question from audience is regarding the phase 3 studies. When you say a comparison with placebo, is just placebo or is treatment as usual, like with SSRI?
Yeah, no, it was, if the woman was on an SSRI when she came in, she stayed on it. So any treatment they were on when they came in, they stayed on. They couldn't have an adjustment in their dose for 2 weeks before. So they came into the hospital and then they were randomized, and they either got the drug or they got a sham. So they had an IV infusion. It just was saline. It wasn't the drug. But yes, it is. Well, is it treatment? I don't know that you could say it's treatment as usual, right? Because if it were treatment as usual, then at some point somebody might have changed drug or increased the dose if the woman wasn't getting better, and instead they just held it steady. But they did have some kind of psychiatric medication on board, most of them.
Great. Professor Estes, do you have any other question?
I'm really fine. Thank you so much, Lauren.
I'm really happy. Professor Verates, do you have any other comments or questions? Your audio is muted.
No, no questions. Just again saying it's very, very helpful. And thank you very much.
It's a complete pleasure. As I said at the beginning, I wish I were there in person. I've never been to Brazil,
Next
but
time.
one day.
Fantastic.
Get a proper invitation to visit.
One day.
Yes.
But it's a great pleasure to meet people in other places and to be able to talk about how important it is that we treat these women.
We are so glad to having your time here with us, and so sharing your time with us. So we are really so glad, and we hope to have you here next time in person. In
One day
Brazil.
we'll do it. One day.
So, Professor Estes, could we end this meeting? Perfect. So, thanks a lot, Lauren. Thanks a lot, Professor Verates. Thanks a lot, Professor Estes. And see you next week to our final meeting of our course. Thank you so much.
Bye.
Bye-bye.
Thank you.
Thank you very much. Bye.
Bye.